Today, I am happy to share the primary results of a cluster randomized controlled trial that accessed a sports-based program called SKILLZ that aimed to provide sexual health education to adolescent girls across a number of secondary schools in Cape Town, South Africa. This study was conducted by the Desmond Tutu Health Foundation in partnership with Grassroots Soccer and received funding from Vive Healthcare's Positive Action for Adolescent program. On the ground, this study was called Goals for Girls. The high rates of STIs, HIV, and unintended pregnancy amongst adolescent girls in South Africa has necessitated ongoing development of sexual health education and promotion programs. However, the delivery of these programs needs to be optimized, and through this study, we wanted to compare the potential impact of a sport-based program that used near-peer coaches with the National South Africa in-school program that is delivered by teachers. The primary aim was then to compare the impact on sexual and reproductive health outcomes, specifically HIV, chlamydia, gonorrhea, and pregnancy, as well as a range of socio-behavioural measures. We also evaluated the feasibility and acceptability of the program, which I will refer to briefly. We conducted this trial amongst 40 schools. The schools were the unit of randomization, and 20 of the 40 schools were randomized to receive the intervention, which was called SKILLZ. The program was offered to up to 100 girls per school, and the study was conducted over a 2-year period, where 10 schools received the intervention in the first year, alongside data collection from 10 control schools. This was called Cohort 1. Then, an additional 10 schools received the intervention in the second year, alongside data collection from a further 10 control schools. This was Cohort 2. This diagram reflects the actual number of schools reached, which was 38. There were 2,792 participants in total, of which 73% attended both study visits. Quantitative measures were collected at baseline and 3 months post-intervention. There was a mixture of self-administrated and nurse-administrated collection tools used. Testing for gonorrhea, chlamydia, HIV, and pregnancy was conducted at the school, and we included a socio-behavioural questionnaire that assessed support structures, gender norms, self-concept, and agency to negotiate safe sex. Analysis and interpretation focused on determining the presence of differences between cohorts and between arms. And a sub-analysis was done for biomedical outcomes to investigate potential differences between high and low program attenders in the intervention arm. A look at participant demographics showed no significant differences across arms or between cohorts. Almost half of participants received a HIV test within the previous year, likely due to the presence of a large HIV testing program that provided free services to adolescents. In addition, more than 40% of participants were in a relationship, and about a third had ever had sex. In Cohort 1, all the schools received an after-school program, and we had a number of traditional support measures in place to support their attendance. However, Cohort 1 showed suboptimal attendance, with less than a third of participants attending 7 or more out of the 10 sessions. Suboptimal attendance then led to a number of program refinements being made with the aim of optimizing attendance in Cohort 2. We considered a few alternative models for program delivery. We quickly ruled out Saturdays and holidays, but we found that in-school sessions, where possible for the school, were a highly promising option. So going into Cohort 2, we gave schools the choice of whether they would like an in-school or an after-school program. And what we found was that schools that opted for the in-school program showed very high attendance, with more than 50% of learners graduating and much fewer not attending a single session. So Cohort 2 overall showed optimized attendance compared to Cohort 1. Taking a look at the impact on STIs, HIV, and pregnancy, STI prevalence was high at baseline at around 16% and increased during the studies in both the control and intervention arms. However, participants that attended more than 7 sessions and graduated from the program showed moderately lower levels of STIs than in the control arm. However, this finding was only significant for gonorrhea, despite chlamydia having a higher baseline prevalence. HIV was unexpectedly low in this study, and no new infections was detected. Incidence of pregnancy was also unexpectedly low, and the same number of pregnancies were reported in both intervention and control arms, so no impact on pregnancy can be attributed to the intervention. Contraceptive prevalence was low compared to national estimates at about 20% and increased by the same amount in both arms. Participants in both arms and cohorts showed evidence of a strong social support system at baseline, with the majority having an older person to talk to if they had a problem or to talk to about sex. Participants also had a highly positive view of themselves, of their bodies, and of their futures. All of these indicators stayed positive throughout the duration of the program, and there were no significant differences after the intervention. Significantly, we did find that high attenders in the intervention arm were more likely to strongly disagree with gendered statements that a man should control relationships when they had sex or be allowed to physically abuse them. High attenders also were more likely to agree that it was their decision to use a condom, regardless of what their male partner wanted. The only starkly divided statement in the questionnaire overall was the question of whether the role of women in the home is to take care of the home and children. And here there was a nearly 50-50 split in whether participants agreed or disagreed with the statement. High attenders of the program were more likely to disagree with this statement. Qualitative data supported these findings, and it showed that participation in the program appeared to improve participants' self-esteem and self-confidence, and we also saw evidence of the formation of healthy relationships and positive peer networks. Here we see quotes from participants saying, "I learned to appreciate my body and have a positive self. I took action by choosing friends," or "I felt more comfortable and confident in wanting to say no to sex." These moderate indications of biomedical and socio-behavioural impact amongst high attenders in an optimized program affirm the potential value of this program, but consistent and high attendance was and is a key determinant of impact. We have multiple reports to show that the intervention was acceptable to the girls and the schools. Yet despite this, there are a number of contextual implementation barriers that need to be addressed in order to realize the potential of such programs in South Africa. I'd like to thank the PIs of the study, Linda Gale Becker, Nancy Padian, the study team, the participating schools, and the learners, and ViV Healthcare for funding this work.